You can start your session now.
Good evening, doctors. Welcome to this
evening.
program, Experience Sharing Program on Managing PPH, Case Studies from Labor Room, brought to you by Hetero Healthcare. Hetero Healthcare, as you know, we have got 25 years of excellence with 36 state-of-art manufacturing facilities. We have 300 plus products in our portfolio and presence in 126 plus countries. We have 21,000 employees globally, and we are amongst the largest manufacturers of ARV, APIs, and FDFs in the world. We have Asia's largest API manufacturing facility at Visakhapatnam, Andhra Pradesh. Hetero Healthcare, the 360-degree solution provider, we strive to fulfill unmet healthcare needs, reaching out to customers across India with wide product range encompassing multiple specialties. We pioneer in quality and innovation, and we have distinction of bringing 4 biosimilar products to market within 5 years of initiation. We welcome you to this experience sharing program on managing PPH, case studies from labor room. Today we have got honorable speaker, Dr. Jaya Trivedi with us. Welcome, madam. Welcome to this program. Dr. Jaya Trivedi is MBBS gold medalist, MS, DNB, FMAS, diploma in cosmetic gynecology, laparoscopic surgery and infertility specialty at Vedanta Hospital, Aryanagar, Kanpur. Madam is life member of Oxy AMASI, IMA, MBBS from SN Medical College, Agra, and got 5 gold medals in MBBS. Wow, madam. Fellowship in gynecological endoscopy from Marigold Women's Hospital. Presented paper in UPCOG 2019 and published in JCDR Volume 2, Issue 4. Felicitated by Honorable Secretary Sri Ram Janmabhoomi Ayodhya Temple. Madam has attended coloscopy workshop, high risk pregnancy workshop, and various conferences. Welcome, madam, to this program. And I'll run the slide.
Okay. So before wasting time, I would go through our slides. Postpartum hemorrhage, as we all know, it is a well-known and common complication of any delivery, and I must say every obstetrician must have faced this complication at every point in their practice. So it is common, unfortunate, and next please, Dr. Prashant. Dr. Prashant, am I audible? Dr. Prashant? Okay. So postpartum hemorrhage, daunting event, is loss of at least 500 ml blood following vaginal delivery and 1000 ml following C-section. It's common and can occur even in women who are at not risk. I have seen patients who doesn't have any risk factor for postpartum hemorrhage. Still, they went up to postpartum hemorrhage. So it is the leading cause of maternal mortality in low-income countries and even the primary cause of nearly 1/4 of all maternal deaths globally. Next, please. It's common and this is very unfortunate for us. It is the leading cause of maternal mortality, accounting for at least about 35% of all maternal deaths. So it is the leading cause of maternal mortality in developing countries. In developing countries, the maternal mortality ratio was to 40 per lakh live births compared to 16 in developed countries. So in our developing countries, maternal mortality ratio is 1. The global incidence of PPH is 14 million women suffer from PPH, and the incidence reported was 2 to 4% after vaginal delivery and 6% after C-section. So the PPH incidence in India is 38% of maternal deaths are due to PPH, and the global deaths that take place in India contributes to 25.7%, and 2/3 of these is due to PPH. So India has an unexpectedly high maternal death rate due to PPH. Next, please. Now coming to etiology of postpartum hemorrhage. Through our UG days, we used to learn the causes of postpartum hemorrhage by 4 T's, that is tone, thrombin, trauma, and tissue. Tone, that is uterine atony, inability of the uterus to contract, which may lead to continuous bleeding. And second one is thrombin, that is any coagulopathy, that is failure in clotting, and trauma like injury to birth canal or vagina or cervix or even uterine rupture or uterine inversion and lacerations in your any genital tract organ. And fourth one is tissue, that is retention of placenta, clots, membrane, blood in uterine cavity. Next, please. Now coming to clinical findings in PPH. Clinical findings in PPS depends on the degree of shock. There are 4 degrees in shock. One is compensation, second mild, moderate, and severe. In compensation patient, there will be 500 to 1000 ml of blood loss. In mild, there will be 1000 to 1500 ml of blood loss. In moderate, it will be 1500 to 2000 of blood loss. In severe, more than 2 liters of blood loss. Blood pressure changes in compensated patient, there will be no blood pressure change. In mild, there will be slight fall in blood pressure. In moderate PPH, there will be marked fall in blood pressure that is up to 70 to 80 mmHg. And in severe PPH, there will be profound fall of blood pressure. Blood pressure can go up to 40 to 70 systolic mmHg. Sign and symptoms you will see in compensated patient like palpitation, slight dizziness, and tachycardia, while in mild PPH patient, there will be weakness, sweating, tachycardia, and moderate PPH, there will be restlessness and pallor, and even patient can have polyuria also. In severe PPH, you will see collapse and there will be strike for hair hunger, and patient can go up to anemia. What will you see in abdominal findings in PPH? There will be slight abdominal tenderness and can patient go into hemodynamically circulatory collapse, increase in abdominal blood when there will be PPH due to uterine rupture, and a loss of uterine contractions in uterine atony, maternal tachycardia we can find in vital parameters, and there will be gush of bleeding in through vagina. Next, please. So, diagnosing postpartum hemorrhage after seeing the clinical findings in postpartum hemorrhage, you have to diagnose the cause of the postpartum hemorrhage and you have to manage this immediately. So, initially, you have to assess all these parameters. You have to rapidly assess the patient's status, whether it is hemodynamically stable or not. You have to see the signs of tachycardia and hypertension and assess the vital signs and assess the amount of the blood loss. After that, you have to send blood count for checking hemoglobin, hematocrit, and for arrange the PRBC and even platelets. Whatever you require, you have to send blood for that, and coagulation studies and assessment of fibrinogen also. You have to examine the time at the time of the bleeding, entire genital tract for any laceration, any cervical injury, any vaginal tear, any signs of uterine rupture, or even you have to see manually examine the retained placental tissue, any membrane, any blood clots, or membrane. Assessment with bedside ultrasound to check if the uterus is non-contracted, and you can check it by manually also or by ultrasound also. Evaluation of uterus to check for uterine inversion. Sometimes PPH is also due to inversion of the uterus. So to check the uterus for uterine inversion also. Next, please. Now, approach towards postpartum hemorrhage. Now, after categorizing the cause of the postpartum hemorrhage, we have to manage how to approach this case. So, in case of poor uterine atony, poor uterine tone, so in uterine atony, you have to abdominal palpate. You will find uterus is relaxed, boggy, and soft, and fundus will be felt above the umbilicus if the uterine cavity is filled with blood and clots. Now you have to send full blood count, coagulation profile, and all blood parameters like liver function test, electrolytes, kidney function test. And if patient is not responsive to fluid and blood replacement, you have to do an abdominal ultrasound to check whether there is uterine rupture or intraperitoneal bleeding can also happen. So in this case, you have to give uterotonic agents like oxytocin, prostaglandins, or goat alkaloids, uh, and even in case it is not responding, you have to insert the uterine balloon tamponade also. So this is the approach for in case of uterine atony. Now coming to second, if postpartum hemorrhage is due to tear or trauma in any genital tract organ. So bleeding will occur from trauma within genital tract. You have to explore the whole genital tract. You have to see any extension of uterine angles or tears during cesarean section, and extragenital cause like subcapsular live rupture or rupture of ovarian vessels. In this case, whether you see any type of tear in any genital tract organ, you have to repair the genital tract trauma. Or in bleeding due to cases in bleeding due to ovarian or splenic vessel rupture, you have to give pelvic arterial embolization. Now coming to third case, PPS due to retained tissues. In retained tissues, retained placenta or membrane or clots, you have to do examination under general anesthesia and for management, have to manually remove all blood clots, placenta, and membranes under general anesthesia. Now, fourth cause PPS due to coagulopathy. You will find continuous bleeding, uncontracted uterus. For medical management, you have to replace all blood factors, coagulation factors, platelets, plasma, whatever you need, you have to replace the all factors. And if it is not responding, then in only cases you have to surgically improve the patients. So attempts should be made to identify the cause in women who are bleeding in parallel with this excitation. You have to diagnose the cause of the postmortem hemorrhage through 4Ts. Next, please. So there is a rationale for the development of carbetocin in new heat stable formulation. Carbetocin, which is available nowadays, is room temperature stable formulation and convenient while presentation. While oxytocin and ergot alkaloids should be kept in refrigerator to degradation, while it is stable at room temperature. And the heat stable formulation of oxytocin is currently not available. And the previous formulation of carbetocin should be stored between 2 to 8 degrees centigrade. Now it avoids need for any cold chain storage and logistics, and has shelf life of 24 months at 30 degrees centigrade and at 75% humidity. So in resource poor countries do not always have cold chain transport and storage capability. So this was the rationale for the development of carbetocin in new heat stable formulation. Next, please. Use of nucleotonic agent. We can use nucleotonic agent at crowning, at the delivery of enteral shoulder, after delivery of placenta, after second stage of labor, in prophylactic use, in therapeutic use, prophylactically to prevent PPH, in AMTSL, and in case of management of PPH. So nucleotonics molecules, we have oxytocin, carbetocin, ergometrin, symptometrin, misoprostol. These are the molecules which we use commonly. Next, please. Carbetocin. This is a new molecule, a next generation drug for PPH management. This drug is synthetic. It is actually long acting analog of oxytocin. And hello. Hello.
Madam?
Hello.
Hello.
Yes.
Yes,
Now
ma'am.
it is louder.
Yeah. Now it is better, madam. A little louder.
Yeah. A little louder. Now.
Yeah.
Better or not?
Yeah, better. Now it's better.
Better. Okay.
Yeah.
So, in therapeutic indication, prevention of postpartum hemorrhage due to uterine atony. So, carbetocin therapeutic indication we use commonly in prevention of postpartum hemorrhage, and posology and administration 1 vial for IV administration. Carbetocin was created by making several modifications to the oxytocin structure. So it has prolonged half-life and reduced enzymatic degradation. Next, please. Now I will show you the clinical evidences which show that carbetocin is not inferior to oxytocin. As we all know, oxytocin is a synthetic cyclic peptide which is secreted from the posterior pituitary hormone, and it binds to oxytocin receptors in the uterine myometrium. So it causes the contractions of the uterine musculature by increasing the sodium permeability of uterine musculature. Carbetocin also works like this. It is long-acting, actually, synthetic analog of oxytocin, and it also binds to oxytocin receptors in uterine smooth muscle, resulting in rhythmic contractions and increased frequency of existing contractions, and it causes to increase uterine toning. Now, pharmacokinetics of oxytocin, intravenous administration almost immediate action with peak concentration after 30 minutes. And heat stable carbetocin sustain uterine contractions within 2 minutes, and lasting for about 6 minutes and followed by rhythmic contractions for 60 minutes. In IM administration, slower onset of action in case of oxytocin that is taking place 3 to 7 minutes but produces a long-lasting clinical effect up to 60 minutes. In IM cases of carbetocin, sustained uterine contractions lasting for about 11 minutes and rhythmic contractions for 120 in compared to oxytocin. So half-life of oxytocin is 1 to 6 minutes, while in heat stable carbetocin, it is 40 minutes. Storage and transport, oxytocin requires protection from light, storage at 2 to 8 degrees centigrade and continuously to preserve its activity, otherwise it will get disintegrated. While heat stable carbetocin, it is it can store at room temperature up to 30 degrees centigrade. Now coming to clinical indications of oxytocin and heat stable carbetocin. As we know, oxytocin can be used in induction of labor, augmentation of labor, prevention of PPH, treatment of PPH, but heat stable carbetocin is only used in prevention of PPH. Okay, next. This is a WHO champion trial. This was a trial conducted by WHO to show that carbetocin is non-inferior to oxytocin, and it is the largest clinical trial in the prevention of PPH. Trial was conducted by WHO Reproductive Health Research Department. It was a non-inferiority double-blind randomized trial, and the objective was to compare the effectiveness and the safety of investigation due to stable carbetocin to oxytocin in the prevention of PPH after vaginal birth. There were 30,000 women enrolled across 10 countries, including in India. The primary outcome was the proportion of women with blood loss of at least 500 ml or the use of additional uterotonic agents, and the proportion of women with blood loss of at least 1000 ml. Next. Carbetocin or oxytocin was compared in case of blood loss of more than 500 ml. The efficacy was found to be almost similar in case of carbetocin and oxytocin. And in case of parameter blood loss more than 1000 ml, the efficacy in case of carbetocin was 1.51%, and in case of oxytocin, it was 1.45%. In case of safety, at least one unanticipated adverse effect was 4.9% in case of carbetocin and 4.7% in case of oxytocin. So, so the frequency of expected adverse effects does not differ significantly between carbetocin and oxytocin, and the frequency of blood loss of at least 500 and the use of additional uterotonic agents with carbetocin is proven to be non-inferior versus oxytocin. So the use of additional uterotonic agents and interventions to stop bleeding and adverse effects did not differ significantly between the two groups. So it was non-inferior to oxytocin for the prevention of blood loss of at least 500 ml for the use of additional uterotonic agents. It was a result of the champion trial conducted by WHO. There is also a Cochrane review. Cochrane says that carbetocin for preventing postpartum hemorrhage. In this review, data from 11 studies, 265 women were enrolled. The author concluded that the women who undergo cesarean section, carbetocin resulted in statistically significant reduction in the need for therapeutic uterotonics compared to oxytocin, and also carbetocin is associated with less blood loss compared to symptometry in the prevention of PPH for women who have vaginal deliveries, and is associated with significantly fewer side effects. Guidelines recognizing the benefits of carbetocin for preventing uterine toning. There are many guidelines by various organizations. WHO guidelines for PPH prophylaxis is you have to use only one of the following in these uterotonic agents. You can use oxytocin, carbetocin, misoprostol, artemetrin, methylaglomethrin, oxytocin, or combined artemetrin fixed combination. SOGC suggests that you have to use carbetocin 1000 microgram IV bolus prevention of PPH. Ranscope New Zealand guideline you have to use in AMTSM and as a prophylactic uterotonics for carbetocin. People suggest that carbetocin one of the recommendations for PPS management, and Germany, Austria case body also suggests carbetocin. FCUG France also suggests carbetocin on proving non-inferiority to oxytocin achieved by champion trial. There are different guidelines who suggest that this is the one of the drug used for prevention of PPH prophylaxis. Next.
Madam, thank you very much.
Now,
Yeah,
okay.
coming to your experience, since how long you have been using Carbetocin, madam?
I have been using since last 2 years,
2 years.
actually. And
And-
I'm using for prevention, actually.
Yeah, but that's where it is recommended. It's
That's
indicated.
right.
Yes, yes. There are
Yeah.
many studies that show that it's very good for prevention of
Yeah.
PPH. And you use generally IV or IM?
IV. Actually, I generally use IV for immediate effect, actually.
Yeah. And you use in both cesarean section deliveries as well as the normal
Yeah,
deliveries?
both cesarean and cesarean. I have kept in labor room also and in OT also.
OT also. In
Yeah.
fact, coming to your cases,
Uh,
yes.
This was my case. 28 years old, primary gravida at 39 weeks gestation, came in labor, in active labor. Otherwise, her antenatal period was uneventful. Her vitals were pulse rate 102 per minute, blood pressure 130 by 80 mmHg. Her HP was 9.2. Rest blood parameters were normal. She was having adequate contractions, and PV findings were 7 centimeters cervical dilatation, cervix fully placed, and had a zero gestation, between meconium lighter. So it was she was in active labor actually. She delivered vaginally just 15 minutes with the aid of right midlateral episiotomy. AMPSL was done, placenta delivered with all membranes intact via controlled contraction. Now, what we saw that after delivery of placenta, it was noted they was bleeding from vagina. Next, please. So, I used Cinto 40 unit. This is my protocol actually. In case of PPH, I usually use Cinto 40 unit in 500 ml and start at 60 drops per minute, and Methergine and Trenexa. These are the three drugs I usually use in my any PPH patient. And after that, tablet was also started, and her BP started to fall. So actually, her resuscitation was started. Still bleeding was present. So I think on that day, carbetocin was not available in my labor room. So carbocloth was given, and the tracking introduced available. After 5 minutes, tabs removed because bleeding was coming from continuously from uterine cavity. And after that, injection carbetocin was given. Carbetocin given, and Chhattisgarh balloon tempo node was done. After 15 to 20 minutes, bleeding secured, and patient shifted to SDU for vitals monitoring, and she remained stable and discharged after 3 days of hospital stay. So this was a case which was not high risk actually, and I
Yes.
had to use many even carbetocin and many hypotonic agents
Correct.
for PPH prevention. I think prevention is a PPH management. Now coming to case 2, 36 years female, G2A1 with history of laparoscopic myomectomy 2 years back to 37 weeks pregnancy with complete placenta previa, got admitted in hospital 1 month back. She had one episode of bleeding previa, 34-week gestation. So that time she was managed conservatively. Her elective analysis was planned after delivery and placenta. What we saw that there was bleeding coming from placenta attachment bedside. So I have taken multiple square sutures from that site. Still bleeding was present, and I did bilateral uterine ligation. Still bleeding was present. And after that, injection carbetocin was given, and bleeding reduced. And for same site, I introduced the retardant roller gauze piping, and the one end kept is in vagina. After 24 hours, I have removed the packing, and bleeding period was normal. Patient discharged after 4 days. This is the case 3, G2P1L0, 36 years female, 38 pregnancy with non-live issue with previous cesarean presentation. In labor, got admitted. Emergency LSCS was performed. After delivery of baby in the center, sudden gush of blood from uterine cavity, and it was clearly anatonic. I started even injection carbetocin was given prophylactically in this case, and after that there was bleeding. I have to give injection symptomethergin and carboprost and even carbetocin also. Instead, uterus remained flabby, and I did the bilateral uterine artery ligation also. And after all this measure, even uterus remained atonic, and her vitals went up to 40 systole. So, uterus remained atonic. Even all these measures, so decision of peripartum hysterectomy I have to take, and consent was taken during OT, and subtotal peripartum hysterectomy I did, and it was achieved after hysterectomy. And this was the case in which I had to do hysterectomy for PPH treatment. The patient did not respond to any uterotonic agent, and uterus remained flabby and flabby. And for life-saving surgery, I had to do hysterectomy for this patient. And after 3-4 days, she remained stable and discharged in stable condition.
Right, madam. Thank you so much for sharing your case. You have seen that, sometimes carbetocin may not work, but generally it works in most of the cases.
Yeah,
Yes, it can
generally
happen.
it
Yes.
works in most of the cases. It
I
was
mean,
the case,
sometimes
I
it would
think,
always happen. Yeah.
yeah, this was
There's
the
some
case
unknown
actually.
factors. Yes. There are some patients where you would anticipate a PPH, no, madam?
Yeah, many cases where when you have high risk factors like severe anemia patients or twin pregnancy or increased blood pressure or complete placenta previa or abruption, there are chances of blood
Fibroids.
postpartum hemorrhage,
But I suppose
fibroids.
yes. In our country, I suppose anemia could be a major cause.
Yeah, anemia, infection. Anemia is the major cause in our
Major
countries
cause.
actually. Yeah.
Even diabetes and PIH can also.
Yeah, PIH is the most the leading cause of actually
Okay.
PPH. So you will see PPH in case of PIH and diabetics and type 2 diabetes or GDM. You will see PPH.
And your experience, madam, in use of carbetocin in case of retained placenta?
Yeah, we can use carbetocin in case of retained placenta also. Actually, it will cause rhythmic uterine contraction, so it will help in expansion of retained placenta. It is helpful actually.
Have you had the occasion to use it in retained placenta anytime?
No, I have not used it, but it will help. I think it will help.
And in case of Rh negative mothers?
Yeah, I have used carbetocin in Rh negative mother. There is no contraindication
There is no contraindication
in Rh negative mothers.
Now, this is, can a doctor use carbetocin for prevention of PPH if oxytocin is used for labor induction?
Yeah, doctor can use.
So most of us use oxytocin for labor induction.
Oxytocin is actually used for labor induction.
Yeah.
So, carbetocin is good for prevention.
The fear is because they act on same receptors, would it work?
Yeah, it actually acts on the same receptors, but its half-life is 3
oxytocin half-life is very short, so it would,
so it will help actually.
Yeah. In which case, you generally prefer IV, but for the audience, would there be some cases where IM could be beneficial in case of IV?
In some cases, like in elective LFCH, you are anticipating PPH or like fibroid history of laparoscopic myomectomy, you can use iron.
And for where at some places there may not be immediate facility for IV, there may not be immediate help.
If
that could,
is not there, you can use iron by any staff. In that case, you can use an iron.
In fact, that could be one of the major advantage with this drug. You don't require a cold chain, and you can get IM, IV depending on the situation, and a single dose required.
This is the advantage actually in case of carbetocin. It can be given by any staff in a staff in OT or in labor room.
Yes, it wouldn't require high skill.
No.
Are there any, I will not say deadly complications, are there any side effects of carbetocin?
No, I have not seen any deadly complication.
Thank God. PPH itself is a deadly condition.
No.
PPH is one condition where it is good to discuss, good to analyze, but one should never get a case of PPH.
So, whether those can, it can be repeated, but I think I don't have any case where I have
and there are no documentation of repetition also.
No.
People, yes. Like, you have used other uterotonics in your case presentation.
Like carbetocin can be repeated, carboprost can be repeated.
Exactly. And what are the advantages of carbetocin over azithromycin in terms of mode of action, in terms of adverse effects?
Actually, there are more advantages. Like it doesn't require any room storage,
Storage,
refrigeration.
yes.
But that's the one point, and it has prolonged half-life. That's the second point.
Correct.
And it doesn't require any expertise in it can be given 1 ml doesn't 1 ml IV installed by any staff. So has advantage over. You have to tell staff that ये वाला injection लगाना लगा हो जाता है.
Yeah. Should carbetocin be kept as a reserve drug, or should be used as a first line?
I think it should be used as a first drug, whether
correct.
you are where you are anticipating PPH.
Yes,
So it
yes,
should be used as a first drug.
first line. You have seen in other drugs will also work, it wouldn't happen.
Yeah.
What is the role of anesthetist in your setting? Which is a big hospital, anesthetist will also play a role. Is it the anesthetist is taking a call, or the gynecologist in case of a
No, it is the gynecologist.
gynecologist?
But,
Yeah.
it is the gynecologist.
Of course, with understanding of anesthetist, and this always works as a team. It's always a team effort. Yeah.
Yeah.
To conclude, your take-home message to the audience.
Yeah, I would say that it is a good drug for prevention of PPH, and actually we don't want to see any patient in PPH.
Absolutely.
We don't want any patient PPH में. So as we know, prevention is better than cure.
Absolutely,
So,
absolutely.
prevention is better than cure. So this drug is very good, and now the cheaper prices are also available in this one vial. So you can use any patient, patient, where you are expecting any PPH complication like twin anemia, PIH, diabetes. So it is a good drug for prevention of PPH. And there are two factors. It doesn't require the refrigeration.
Yeah.
ये बहुत problem रहता है oxytocin.
Correct.
It doesn't work. It is too stable. That's very good point in carbetocin.
Thanks, madam. In fact, as you rightly said, the storage condition is very important in our country. Even in cities, big cities, there is always a power outage.
In case of oxytocin,
Yes.
efficacy get reduced. Whether you are using it as induction or augmentation.
Absolutely,
so
absolutely.
That's a very good point in case of carbetocin.
Yes.
Actually, I like it.
Yes, correct.
Mm.
Thank you so much, madam, for sharing your experience. I'm sure the audience has benefited. What happens is that although there are many studies and there are many case papers and many references, our own doctor's experiences always helps our other doctors, always helps. It gives them more confidence and more insights into the drug and condition. Thanks so much for sharing your experience and case studies. Thanks all the doctors who could took time from the schedule and attended these sessions. Thank you, marketing team. Thank you, sales team, for super coordination. Thanks, IT team, for support. Thank you so much. You can log off, madam, and wish you a happy evening and happy weekend. Thank you.
Thank you.
Thanks, Bivas. Thanks, Sanjana. You can log off, madam.
Okay, thank you.
Madam, thank you so much once again, ma'am.
Thank you.
Thank you. You can log off.